Dr. Namrata, okay. So that's fine. We're reorienting to the original program, Achieving Brilliance in Trifocal Outcomes with Bliss Technology, Optiflex Trio, Dr. Namrata. So a little bit of introduction. None of the authors or none of the presenters or panelists have any financial interests in the products being mentioned. This is another important move towards our Make in India initiative. Welcome Dr. Krishna Prasad. Please join as expert. Yes. Any comments you'd like to make, Dr. Grover?
Looking forward to a nice session where we'll discuss all the technical aspects of the IOL advancements that have taken place and the advancements in Make in India. So both aspects we'll look at.
Thank you. Dr. Rajendra Prasad, would you like to add anything while we're waiting for the first presentation? Have you any experience with using these lenses? As a very senior and experienced surgeon, any comments while the slides are coming up?
Yeah, thank you very much. And I think this session is going to be very interesting because this is an Indian product, Biotech. IOLs we all have been using, and with a very good acceptance of these IOLs in our practice.
Thank you so much. Dr. Namrata is now ready. So we will start with the doc on Achieving Brilliance in Trifocal Outcomes with Bliss Technology, Optiflex Trio.
So thank you, Dr. Radhika. I would be talking about patient expectations from these premium surgeries, and especially the cases which we have done with Optiflex Trio. Can we have attention, please? And yes. Thank you. So there are no financial or proprietary disclosures, and patient expectation from premium surgeries that we should have good contrast, spectacle independence, minimum glare and halos, and this should be there for near vision, intermediate vision and far vision. And where and how to begin is we have to see the occupational lifestyle, patient counseling is the key, and also the realistic expectations of the patients that are required. Optiflex Trio lenses are trifocal, aspheric, hydrophobic, natural yellow lens with a Bliss technology. That means the brilliant light sensing system, which is a trifocal intraocular lens for presbyopia correction. And it is a single piece refractive 360 degrees square edge with aspheric optic with the intermediate addition of plus 1.85, near add of plus 3.5, optic size of 6 millimeter, and the overall size is 13 millimeter. It has an angulation of 0 degrees, and it ranges in diopter from 7 to 30 and in cylinder from 0 to 6 diopters. Then if we see the design, it has been designed for natural adaptation so that there is effective utilization of the unused light energy, optimum asymmetric and balanced light distribution at each focal point, and especially the optimized diffractive zones for intermediate and near vision without affecting the distance vision. There are 12 diffractive rings and there is minimal pupil dependency. So we see the light transmittance curve compared with a human, natural human lens. It is very much similar to that. And additionally, Optiflex also blocks the harmful UV light and filters the violet and the blue light without losing the contrast sensitivity. The transmittance property is similar to the transmittance property of a young human crystalline lens for visible spectrum. Now, the optimum asymmetric and balanced light distribution is 45% for far, 27% for intermediate, and 28% for near distance, and it provides excellent vision at all distances. And the minimum loss of light is there, which yields 88.3% of the light for sharp and clear vision at various distances. If you look at the modulation transfer function, there's smooth transition between zones, which minimizes glare and halos. It is glistening free, and there's maximum light transmittance with uninterrupted functional vision. Now, this is the study that we did at RP Center in 100 eyes, and the pre-op, the post-op day 1, month 1, 3 months, 6 months, and 1 year follow-up details are available with us, and the endpoints were visual acuity, quality of vision, rate of PCO, retinal detachment, ease of fundus visualization, etc. Then the inclusion criteria, we took bilateral age-related senile cataract with grade of cataract permitting optical biometry, no ocular or systemic contraindication for surgery, and corneal astigmatism of less than 1 diopter. And the exclusion criteria was posterior segment pathology, media opacity other than cataract, corneal higher order aberrations more than 0.3, and patients with with potential of intraoperative complications such as floppy iris syndrome and pseudoexfoliation syndrome, etc. So the target was that both eyes had to achieve emetropia, and IOL Master Barrett's Universal True formula was followed, and we also did eye trace, aberrometry and topography for these patients. So there is nothing much to the surgery because it is very simple, it is very easy to load these lenses, and it was loaded in a cartridge in which the viscoelastic was placed, and this is the Optiflex Trio lens which has got multiple rings, and this is then loaded onto the cartridge, and subsequently the cartridge was closed, and the cartridge that now the company gives is actually very good and very smooth, and there are hardly any problems with it. If you've made a 2.2 incision, you don't have to increase it because the cartridge goes very well with this, and the lens unfolds in a very controlled and a gentle manner inside the anterior chamber. Now, this is just to show the uncorrected visual acuity at 1 year follow-up, and 80 eyes completed this 1 year follow-up, and the uncorrected intermediate visual acuity also 80 eyes completed the follow-up with good intermediate vision, as can be seen here. Now, if you see the near visual acuity, again, it was acceptable for all the patients, and most of the patients did become spectacle-free. The spherical equivalent is as shown and doesn't vary much in the post-operative period, and this is the 1 year spherical refractive outcome. 98% of the eyes had residual sphere in the range of 0 to 0.5 diopters at 1 year. And this is pre and post 1 year contrast, which also can be seen here, and this again is very much better as compared to the preoperative status. Now this is the eye trace, the high order aberrations, they improve in the post-operative period, and as per our analysis, they become better when we compare at 1 month and 1 year. This is yet another aberration profile which you can see pre and post 1 year eye trace. And this is the modulation transfer factor, which also is shown to be optimal at 1 year follow-up. So this is actually the supportive design which I was earlier talking about. The range, it provides 35 to 90 centimeter range of intermediate near vision and 38 centimeters of near focal point, 72 centimeters of intermediate focal point, and because of this, there's extended depth of focus for daily activities. Now, subjectively also we wanted to see whether the patient benefits or not, so the reading speed also becomes much better, and especially when you bilaterally implant the patients, then the effect is seen much more, and then when you do the subjective evaluation satisfaction for surgery, so the patients are fairly satisfied, 82% were very satisfied, and when you combine these two, almost all patients, 100% of the patients were satisfied. As far as the recognizing faces and reading newspaper is concerned, also showed good correlation. Almost 94% of the patients were happy that they could read the newspaper or see the price tags and even walk on the uneven ground. To carry out any activity, again the satisfaction index was almost to the tune of 100%, and of course routine activity, they were 94% of the patients were able to carry out themselves, and 6% of the patients were fairly satisfied. So to conclude, the Optiflex Trio gives excellent uncorrected visual acuity at all distances. More importantly, it gives 100% spectacle independence. There may be low incidence of glare and glelos, and this is acceptable. Also, it reduces over a period of time. The contrast sensitivity and the optical quality are satisfactory, and at the end of 1 year, there is no posterior capsular opacification. So, thank you very much for your kind attention.
Thank you so much, Namrata. That was a very wonderful study, and the results are very, very encouraging, almost seeming to match any other international product. Would Dr. Gaurav or Dr. Krishna Prasad Kudlu like to say any comments? And then I have 2 questions of my own.
Yeah, from evaluation till the usage, I use this product, madam. As we are talking about Make in India product, but if you compare with any other trifocals, what madam had showed on her presentation about the light biodistribution is almost 88.3, which is the highest. And the amount of glare and halos because of their technology is very good. And what we found out in our initial part of the trial only, their defocus curve is one of the, something like not sharp, it is more towards a smoother side. That might be the reason for lesser glare and halos. I think lens to see in the coming days, madam.
Excellent. Dr. Gaurav, any comments?
So I think my patients have been very satisfied and especially the intermediate and near ranges are both looked after quite well, and the complaints of glare have gone down drastically with the current generation of lenses. It compares very well to any of the top branded ones, and even better as far as the patient satisfactions and outcomes go.
That would be really nice. Namrata, two questions from me. First one is that I noticed that the lens is liquid. I mean, it's dispensed in a fluid, which is usually what we associate with hydrophilic lenses. So, is there any reason why it is dispensed in a fluid rather than the dry form?
It is.
Can you put on the mic?
It is not a hydrophilic lens in that sense, because only the coating over there is hydrophilic, but essentially it doesn't have the hydrophilic properties. So that way I think it is safe. But because of the fact that it is on the outer side coated with a hydrophilic coating, that's why it's...
Okay, so it's a hydrophobic lens with all the benefits. The other question is, generally the push is that if you have a trifocal or a multifocal lens in one eye, then you encourage the patient to quickly have the other eye done. So in your experience of these 100 cases, did they all have the other eye done, or were they okay with maybe a monofocal in the other eye, or were they okay with their normal crystalline lens in the other eye?
We took patients who had bilateral immature senile cataract, and we did not take any patient in which the fellow eye had, or the patient had a pseudophakia in the fellow eye. So as a result, I think that we will not be able to comment on that. But then most patients in our cohort, they got surgery in the fellow eye done fairly quickly, in the sense that there was a gap of not more than 2 months between the two eyes. I think once they also get one eye operated, they see better with that eye, and so relatively the other eye also looks, is kind of hazy. So that is why they are keen to get operated in the other eye also. Because in terms of contrast, it makes a lot of difference.
But it's good that they were able to go up to 2 months, like they didn't force you, कि एक ही हफ्ते बाद करो. So they were able to tolerate
it was
that.
Like 2
yes,
so
that's a very important
2
thing.
weeks to 2 months.
Right, so that's good. Excellent.
I have a question. When the enormous zone is just 1 millimeter, and this is basically for the distance, so can it lead to some amount of more amount of glare and haloing?
So, as would be expected, that there would be more glare and halos, but their experience showed that it didn't. So maybe it is because of the transition. Dr. Namrata, would like to say?
In our cohort of patients, we didn't find any glare or halos. They didn't complain of, and we didn't actually ask them also. We didn't ask this. I mean, we normally don't ask this question unless the patient complains, because otherwise, the patient starts complaining. So otherwise, what we basically looked at was the subjective kind of a questionnaire, so that in his daily activities or her daily activities, the patient is, hampered or not.
And
So
one more question.
Actually, if you look at the construction of the lens, the optic, it has a refractive at the center, then you have a diffractive zone which is only 4 millimeters. So it's a combination of the refractive and diffractive. So if you have a lesser zone of the diffractive, the chances of having glare and halos are less. So that is why this lens actually, if you put this lens in the patients, they complain very least halos and dysphotopsia. The reason behind is because the central zone, which is working for the distance, is not disturbed at all with the diffractive zone. The diffractive zone is only 4 millimeter. So that is the reason they have very less amount of the halos and dysphotopsia.
And one more question. Was the rationale of making it hydrophilic coated, hydrophobic being coated by a hydrophilic?
To reduce the glistening.
So to decrease the it
so that's why it's kept in the fluid, no? Because these lenses, if you look at the other lenses, like especially the Alcon lenses, they tend to get more of glistening because of they are exposed in the dry atmosphere first and then to the high temperature, and then suddenly it goes into the water. So the vacuole formation in the lens creates the glistening. But here, you're already, the surface is modulated, and if you're keeping the lens in the fluid already, and once it goes into the fluid inside, there are very less chances of having glistening.
So I'm glad that your study endorses what our clinical experience had been, then about 50 cases, and have been extremely happy with the subjective part of it. We've not done a study, so the patients have been extremely satisfied. I've not had a single dissatisfied patient because of glare or halos. So that bears out. And the question about Radhika's the delay between the two eyes, I think with most of our trifocals, in spite of them being informed, there always are a significant number of patients in our cohort who prefer to have a second surgery much later. In fact, you see them coming a year after or so. But they're not patients who are dissatisfied, because if they were, they would come earlier. So I think we don't really always succeed in getting them to be operated earlier for better cortical adaptation.
Thanks a lot. I think that was a wonderful interaction. We can go ahead with the next lecture or the experience shared by Dr. Rajesh Sinha, creating a new standard in advanced monofocal technology with Icral Search Toric, expert's view.
Thank you, ma'am. Very good afternoon to all of you. I'll be talking about advancement in monofocal technology. Well, IOL has evolved quite a lot. It was long back, I don't have any financial interest before I start, I must say that. Long back in 1949, when Harold Ridley first described the first IOL, it was quite primitive at that time, and the idea was just to replace something in place of the crystalline lens that was removed. And things have evolved over time, not only in the subject of the material of IOL, but also in terms of the injector systems, implantation systems, delivery system, and that is how things started evolving. And in the mid-70s, what happened that the target was to achieve an IOL, to put an IOL in place, and in 80s, the target was to have a 6/6 vision. Then what happened that people started asking that if I have put the IOL, why to use spectacles? And then came the concept of multifocal IOLs, and then multifocal IOLs had its own problems because of the diffractive steps, as Dr. Rajendra Prasad was just now mentioning, and glare and halos. And there are certain conditions wherein you can't place the multifocal IOLs, like diabetic retinopathy or somebody who is very sensitive to glare and halos. And in such cases, monofocal lenses are very good, and if there is a monofocal lens which has some degree of increase in defocus, then that will provide a reasonable intermediate vision with, and when you implant it in both the eyes, it will work good, and it will have a good intermediate vision, and little bit of near management can also be done by taking the object a little away, and you can manage. Now, intermediate vision has become very important these days because of the use of laptops. Right now, I'm using the laptop, looking at it, and the intermediate vision is only working. So that is one of the most important reasons why over the last couple of decades, the concept of increasing depth of focus of IOL and in having better intermediate vision has come into play, and people like to do that. But then by doing all those combinations, because the initial EDOF lenses, when it came with some rings, and those rings had some problems. And then again, people started telling that why to use these if we have those diffractive rings or the rings which are creating glare and halos, why not put a trifocal lens or a multifocal lens in the eye? Why to put this lens? And that is how people started thinking of improving the depth of focus by having advanced monofocal IOL. And in the same direction, this is a good Make in India material, that is Acryl Cert, which is a hydrophobic acrylic material, and it has a nice square edge on all sides and 6mm lens with 13mm overall diameter, and it provides reasonably good vision. It has a unique zonal asymmetric power distribution. Now this kind of a picture doesn't mean that it has steps or anything. It is just the distribution of power. So zone 1 and 3 having higher power to provide distance to intermediate vision, zone 2 and 5 having minimal power to provide the distance vision, and then similarly, zone 4 contains the nominal and higher power at 60 degrees intervals to balance the energy in photopic and scotopic light conditions. So it is distributed in such a way that the power is distributed and it's not the step. So that is how it provides some depth of focus without causing any photic phenomenon, without causing any, and most of the photic phenomenon happen because of the splitting of light. So if there are no diffractive steps, then the splitting of light doesn't happen. And that is the advantage of this optimization of this lens. And the Acryl Cert IOL is a monofocal IOL, but it has a good depth of focus. And that is what has been shown in studies. With, as I said, 1.75 depth of field is helpful for intermediate distance range, and that is what it is provided by these Acryl Cert lenses. And a lot of patients do have some degree of corneal cylinder in the eye as well. So multiple companies came up with these advanced monofocal with giving the advantage of toric. And Acryl Cert toric is again an Indian company, Biotech. I have no financial interest, but this is a lens which has come up with a toric on a toric platform as well, with all these powers available. And I will just show how this lens is provided to you and how you can implant. It is a preloaded lens. That is an advantage. These days a lot of people are going for preloaded lens because we do get complications related to loading, related to pushing it hard and causing ruptures and all that. So I'm just showing you how, from the external camera view, how it looks like. So this is the Acryl Cert toric injector system, and this is the tip. This is here what you do, you put some fluid here. I will show the microscope view as well. And then after that you inject viscoelastic. After injecting viscoelastic, you, on both sides, under both flanges, you just close the wings so that it folds, and then you push this posterior limb, and as you push it anteriorly, so the lens also migrates, and then after that, with the movement of this, you can implant the IOL. So the advantage is that it is a single-handed implantation. So I'll just go to the microscope view now, and this is how it looks like. So this is a Acryl Cert toric wherein the Callisto system is being used to provide the reference marking. This is how it looks like, and this is with your index finger you can just move and you can implant the IOL. And these are the two posterior limbs which are pushed. So first you inject fluid from behind, and as well as you want to replace all the air, so you also fill it from posterior part, and then you push the IOL a little bit so that it fixes, it engages, because after that you inject viscoelastic. Otherwise, if you don't engage it and inject viscoelastic, it may get displaced. So that is the advantage. And then you inject viscoelastic on both sides, then you close the wings, And then, as I told you, you push this posterior plunger so that it pushes the lens to a position from where it can be implanted. So as it is pushed, you can see here the movement of the IOL, and the IOL has come just behind the tip of this cartridge. And then you, with movement of single finger, you can implant it. And the advantage is that with a 2.2 millimeter incision, you can inject it, you can put the tip of the cartridge inside, and it can be injected into the bag. This is how it is done, and as you just use one finger to advance the IOL, so the IOL does not move inside with a jerk. So the IOL is there inside the bag, and then it is dialed. And then, as we all do for all the toric implants, you can see these refractive zones, which sometimes you do get reflections from there, but since they are not steps, they don't cause any photic phenomenon. And then, as in any toric IOL, you remove the viscoelastic from anterior, ahead of the IOL, and from the front as well as from behind. And then the idea is to have a perfectly aligned IOL, and this is what it is, perfectly aligned on this on the desired axis. This is one study that we have just started at our center, that is on ICRISA toric study, wherein we are comparing two groups of IOLs, two types of IOLs. One is the ICRISA toric and the other one is iHands toric. And we want to see the visual performance as well as the advantages of implantation, because both are on preloaded platforms. So the advantage is that you would like to know that what is the exact difference between the two platforms. And the primary endpoint will be the visual acuity, and the secondary endpoints are all these rotational stability as well as manifest refraction and the ease of implantation. And patients will be those patients who have senile cataract, don't have any other pathology, they will be included in the study. Bilateral cataract, because you want to, we would also do the stereopsis, which has not been mentioned here, but we are planning to do stereopsis as well in this eye, in these cases. And those who have some systemic disease or some ocular pathologies, severe diabetic retinopathy or some corneal pathology, etc., will be excluded from the study. Now, what we found out that both the systems, iHands toric as well as ICRISA toric, are both preloaded. But ICRISA toric injector system can implant the IOL through a 2.2 millimeter incision. You don't have to enlarge the incision. Fill the chamber with high viscosity viscoelastic, your tip of the cartridge will go inside, and as I had shown in the video, and it goes through a 2.2 millimeter incision. But with the iHands toric system, you require 2.4 millimeter incision for the implantation. The second thing is that it is a single-handed implantation. So you can demonstrate. It doesn't roll, because iHands toric has a screw system. So once you take it inside and screw it, it rolls, the eyeball rolls. But here, you can stabilize with the second hand, and with a single finger, you can rotate, you can push the IOL into the anterior chamber. So that is how there is a greater ease of implantation. We did some visual parameters also, and this is just a week only that we have just done so far 12 eyes and 6 in each group. So we are planning for a bigger study for 30 eyes in each group. And so once we do that, then we will analyze the visual outcome more. But in this, we found out that there was some marginal difference between the this ICRISA toric versus iHands toric, but this was not statistically significant, and we cannot comment on that. In summary, ICRISA toric provides continuous vision from distance to intermediate. There is minimal glare and halos. There is an extended range of vision of more than 1.75 diopter at spectacle plane, and that is an advantage. Good intermediate vision. You can implant it through 2.2 millimeter incision. minimizes the pupil dependency because of the distribution of power, and it does provide satisfactory performance in all lighting conditions in the initial R&D studies, but we have to prove it by our own study, and it has good rotational study. So in conclusion, iSkill Cert is a monofocal IOL with some degree of defocus curve, which if you implant in both the eyes will provide a very good intermediate vision, and to some extent near as well. And there's no photic phenomenon, as I said, because there's no splitting of light, and there are conditions wherein you can't implant a multifocal IOL, but you can implant these advanced monofocal lenses with some defocus and also covering the toricity. So it does improve the quality of life. So thank you very much for your patient listening. I would like to have feedback from the experienced surgeon sitting here.
Thank you very much, Rajesh. We nicely covered all the relevant points comprehensively. Dr. Rajendra Prasad, you have some experience with the lens. Would you like to add any expert points?
Thank you. Actually, I have used a lot of monofocal IOL. Acryl Cert is a new introduction of theirs, so I haven't used much, but
Acryl Cert Toric has been launched here in this in the AIOS only.
Just launched.
It has not been. It was not launched. So we just started it before it was launched.
Even Acryl Cert also, it's recently launched, not much of time. We have used a lot of monofocals and toric monofocals and all.
Yeah, Rajesh, actually I use this lens even for the evaluation because our hospital is one of their evaluation center from the first day last 10 years. This is something called advanced monofocal lenses which give a very good intermediate vision. Almost around 57 centimeter, it has got a good intermediate and also far intermediate. And what we evaluated, the stability of these lenses are pretty good, and rotational stability also. What we found out that absolutely there is no rotation. Probably what I feel it is a hydrophobic lens also, and the material what they manufacture is called a Benz material, which is something unique material. None of the other companies has been manufacturing, but which is on the more on the expensive side also. But if you talk about the rotational stability and the patient satisfaction, and the price also, I think the lens to see in the coming days, because absolutely no glare and halos, almost 99% of the cases, because some of the other competitors what we they have created a spherical aberration in the center of the optic. Sometimes some of the patient may not be that happy because of depending upon their corneal aberrations also. But here, this is the technology itself is different. Though the chances of glare and halos are going to be much less.
So, Krishna Prasad, two
ease
questions.
Of implantation is very good. Ease of implantation is very good, and it can go through 2.2 millimeters.
So, Krishna Prasad and Rajesh, two questions.
Sir.
Is it N6 vision at 57 that is said? 57 centimeters said to be the vision at the point at which they have good intermediate vision. Is it N6?
Bilaterally, if we implant, yes.
Okay, what is it, N8 or what? Normally, what do you expect with at the intermediate distance of 57 centimeter that is written? What is the visual acuity at 57 centimeters in these lenses?
In these patients? Yeah, if we implant bilaterally, then we do get the N6 vision at 57 centimeters. Unilaterally, it will be a little...
So, have you used monovision, maybe not as a part of the study, and
no,
are you able to get patients spectacle independent with this lens?
I haven't done monovision in any of these because it's a part of project. Maybe later on we can think of doing
Prasad,
it.
have you used micro monovision or monovision with these lenses?
So I normally don't practice micro monovision, but yeah, definitely it's one of the concept to get the intermediate and near vision. But I generally go in for either if the patient's expectation is very high, they want the reading, good reading and good distance vision and intermediate also. So I normally prefer to go in for the trifocal, like their trifocal Optiflex Trio. And if you look at this Optiflex Trio, because this lens is absolutely different from the other trifocal IOL, because the concept here is you have incorporated 3 technology in the lens. The one is the light sensitivity. The second, it gives you a much greater light is passing through the lens to the retina for the illumination. And secondly, because it's a combination of the refractive and diffractive technology. So it gives you, as I said in the beginning, because it gives you very less dysphotopsia, it gives you very good near vision. That is the most important thing. It gives you a very good near vision because that diffracted zone is purely made for the near vision. And then intermediate vision you get from the refracted zones.
Actually, in this lens...
We have one more lecture,
Yes,
so we
ma'am.
have to wind up. There's less time. We can have the discussion over lunch. So with that, I'll invite Professor M. Vanati. She's going to cover a third aspect of this Made in India symposium, the clinical practice of phakic IOLs, my practical experience.
Yeah. Thank you, ma'am. So over the next 10 minutes, I'll talk you through my clinical experience with this new phakic IOL, which we are using at our center now. I have no financial interest here. To start with, I think when we look at refractive corrections, there are refractive surgery options and there are lens-based options here. So I won't delve into the details of those as we are all running short of time here. But when you look at amount of refractive error, FDA limit corrections, which limit us to -10 to +4 here, and where your refractive ablations are not going to help as in correction with LASIK and SMILE, that's where your phakic IOLs come into play when you want to do a glasses removal surgery for those really motivated patients here. So phakic IOLs give you a wider range of correction, and now we do adopt phakic IOLs even for mild to moderate myopias where your corneas are borderline. So the range extends from about -3 to -20 diopters here, and hyperopics for up to about 0.5 to +10 is recommended, but we do only up to the what is available is up to 4 diopters here. When you look at patient selection here, it's pretty much similar to as you would do for all refractive surgeries. So you probably have something extra which you have to do for your phakic IOLs here. So it's always about 21 years of age. You have a stable refraction here, and you take those corneas which are not suitable for refractive ablations here, or the amount of correction required is beyond what is possible by LASIK or SMILE or by refractive surgeries here. Your endo-ACDs need to be above 2.8 mm. The endothelial cell counts, you need a healthy endothelium here, and you would not desire to have any other associated ocular comorbidities when you are considering these options here. Contraindications would be that you have a progressive refractive error, you have other associated ocular comorbidities. When your endothelium is not healthy and and your endo-ACD, please remember endo-ACD is starting from the endothelium here, then these are cases which you probably would not be suitable for considering a phakic IOL here. So the refractive workup is pretty much similar as you would do for any other laser refractive surgeries. What extra you would do is look at the anterior chamber depth in these patients here. So you could adopt a UBM or an ASOCT here, and you would also do a white to white and specular counts on these patients here. The other workups are similar to what you would do for refractive surgery ablations here. So for myopia, you want an endo-ACD above 2.8, and hyperopia, you would look at an endo-ACD above 3 millimeters. But what I would place more emphasis on is an accurate estimation of your white to white. So most of your postoperative problems in phakic IOLs will depend on your white to white measurement. So a measurement which is inaccurate is going to lead to inaccurate sizing of your phakic IOLs, and that would lead to postoperative problems here. The particular concerns which you look at is the manifest refractions, the backward text distance, the calculation softwares here, and I already pointed out in your workup, your white to white and your endo-ACDs. Most of the support for, in terms of power calculations is provided by the personnel related to the company of the lens which you are using in. So what is widely used and what most of us have been more comfortable with because of the long existence and more literature we have is the FDA approved implantable Collamer lenses. But what are the newer ones which we have on the portal here? And we have the IPCL, we have the RIL, and we have the iCryl phakic IOLs here. The iCryl phakic IOL is the only phakic IOL which I use apart from ICL, and I've had a very good experience with using this IOL. This nomograms in terms of ICL availability, all of us are aware of. It's available in anywhere over your textbooks or on the net for you to read up. So I will just share with you our preliminary experience of what we have when we have compared it with the ICL, when we compared our ICRIL phakic and phakic toric phakic IOLs with relation to the ICL implants here. So this is a single piece posterior chamber IOL, and the advantage is it could be inserted through a 2.2 incision. So that, whereas an ICL you would have to use a larger 3.2 incision in these patients here. And these lenses can be customized according to the shape and size of each eye here. They're available in a very wide range of power range in terms of diopters from +10 to -25, and a cylinder of +2 up to 5 here. They are made from an acrylic material with a long duration where its durability is quite long here. So this is the animated picture of the ICRIL phakic IOL and the phakic toric here. I'll tell you more about this. That is about, it's a hydrophilic, it's aspheric, it gives you an optical dia of 6.5 mm here, and they give it to you, and it's available in 4 ranges of overall diameter of 12, 12.5, 13 and 13.5, which is a particular advantage when you look at it. The other factors are comparable to international standards here, and when you look at the phakic toric as well, again it's available in optic sizes of 4.65 to 5.5 here, and the dioptric ranges is 8 to 25, +8 to -25, and cylinder powers of up to 5 and 0.5 dioptric steps here. Then the refractive index of this lens is about 1.46 here. So here you do see a lens which is about which is a 6.5 sized optic diameter and gives you a good pupillary coverage here, gives you a good range, and the added advantage which ICRIL offers is that they always give you a backup lens here. So makes the surgeon a little more stress-free here. So in case something goes wrong, then you do not need to postpone the surgery, and you would be able to have a backup lens for your patients here. The other advantage is the way you place your lenses here. So they do give you in steps of the cylinder placement is in 0, 30, 60, 90, 120, 150. So it gives you a very easy placement of these lenses, and you do not need to rotate too much when you're placing these lenses vis-a-vis what you would have in the ICL phakic IOL. So that is an added advantage when you're looking at ICRIL lenses. Your calculation sheets look like this here, so I'm going to run through this because of lack of time here. So this is how your calculation sheets, your calculations. Again, that is what is most important when you're planning any form of refractive surgery, be it a laser ablative surgery or be it a phakic IOL surgery. This needs to be accurate, and this is what your team needs to be trained on. And if you are having your optomes and if you're having your residents working, this needs to be absolutely accurate, and you need to look at your calculation sheets if you want to pick up any abnormality. So you can place your lenses horizontally this way, and the axis is marked, and the one which is most suitable to the eye which is being operated, that is being dispensed to you, and that helps you to have minimal rotation when you're placing these lenses here. So again, to run you through on a comparative on particular characteristics, the material which is used in ICRIL is not an animal source here, vis-a-vis the porcine source of Collamer which you have in the Evo Visian ICL here. The rest of them are comparable, but when you look at the flexibility, it's a little more rigid or less pliable as you would compare to ICL here, but it affords you the comparable insertion ease here, and being a little more rigid, it usually does not flip in the wrong direction or does not flip upside down. The loading is comparatively easy in these lenses as well, and when you look at data which is currently available to us in terms of, we do not have too much here, but whatever we have is particularly encouraging. Here you do have 5-year results which comes you from international data and does give you a sight and endothelial cell loss which is about 6.9% comparable to what you have, and I think this was is a much older study here, and we do have lesser endothelial cell rate losses when we are looking at our phakic IOL patients. nowadays, given the improvised techniques and the devices which we have with us here. Again, a large-scale study comparing it with ICL from India by Sri Ganesh's group here. Again, they did a comparative study with 25 eyes here, and the range of power dioptric correction was comparable here. The refractive stability and the visual outcome was again comparable in all these cases here. So that is quite encouraging when you look at the data. So it is ICL is a non-inferior lens if you do look at, so which is comparable, and I think it's a good alternative to be considered when you're looking at an alternative to ICL in these in our eyes here. So the durability here again from whatever data which we are having with us, and we look at the material durability is supposed to be valid for a long period of time here, and the production also uses the zero technology, which means you have lesser impurities, you have a zero methacrylic acid and zero ionization, which is a safe material here. Again, another look at one of our patients' calculation sheets here, and this is provided to you, and this makes you comfortable and guides you of how you would want to place the lenses in your patient. So I will just share the preliminary data which we have completed in 70 patients of our 35 in each group as a comparative study vis-a-vis what we now accept or use as gold standard with ICL. So we have compared our results here. So all our investigation parameters are pretty much similar, and I think I would just share our preliminary data of 38 eyes, 19 patients. The mean pre-op spherical refractive error range of -4 to -24, and a mean pre-op cylindrical cylinder from 0 to -3.5 here. And you could see our visual results are very, very encouraging, are acceptable in all our patients here. We have a safety index of 1.43 and an efficacy index of 1.02 in our patients. And the mean endothelial cell loss in all our eyes is less than 2. It's just about 2. It's 2.1% here in these patients here. And a quick look at the loading system again has been made very easy and very comparable to what we have with ICL, so that we don't have a confusion on this patient. I'll sort of speed it up for you, so you won't run it slowly, but this is a very, very user-friendly, and you could load it yourself here. So there you find the cartridge which you open up and place here. The lens is taken out from its holding container here, and it's pretty much, you could just easily handle it with your McPherson's or any other which you would use atraumatic forceps you want to hold it. You place it such that, and you please remember that your the leading hole on the aptic is on the left side, and the following hole and the hole which follows is on the right side. So that's how it's a little different from ICL here. So it's pretty much to your is similar to the IOL loading which you would do for your cataract surgery. So nothing different, but only thing, remember, you probably will have to place it with the convexity facing downwards here. So that's the difference in this. So it's a very simple loading system you have, and I'll just quickly fast forward. These are all unedited videos, and you could see that I think this is this again is another similar loading system for you to see here. And so topical surgery, again, you need to prep your patients here and make them more comfortable. And here is one of the toric lenses. It's the marking done as we are saying. I'm seated temporarily for this particular patient here. The procedure is very much similar. You can see the ease of insertion. So here it just goes in. It's a little less pliable, so that makes it difficult to get roll upon itself unless you've made an error in the loading of your lens here. And the lens is gone, and so inserting it behind the iris again becomes easier when you want to place the push the haptics behind into the position here. We also use the AIOC2024, so we have more parameters which we are evaluating. We'll shortly share more in our data after it's available for more public viewing. So that's the AIOC2024 showing you the anterior chamber vault, which is measured for all our patients in our cases here. I think I will stop here and thank you all for your patient listening and the opportunity.
Thank you very much, Vanati. It was a wonderful presentation. We'll have a quick comment by Dr. Kudlu and then we'll wind up
Thank
the
you,
session.
madam. We are already 2 minutes delay from our session. I am the initial starter of this lens. I had used 500 plus lenses, both toric and spherical lenses. And as madam said that the incision size is around 2.8. What I just wanted to tell...
2.2 now. Initially 2.8.
Yeah. Now it is 2.2. Initially we started with 2.8. So why am I insisting here 2.8? We even during the trial period, just because of the request from the company, we just wanted to try in a couple of patients how we can explant these lenses. But in spite of it is a hydrophilic in nature, I could able to explant without extending the more than 2.8. Because if you see the other lenses, if you put 3.2, then you have to expand around 3.4 to 3.6 for explantation. Here, it doesn't require. And the one more other point, you will get in a very wide range. That is like one patient I implanted almost around 24 diopter with 4 cylinders.
The expanded
almost
range
28
is a big
diopters.
benefit.
It could able to give the fantastic results. And the overall visual outcome, I can say this is one of the best. There is no difference between porcelain and hydrophilic. Everything is hydrophilic only. There is a porcelain coated lens. Again, I always used to tell, I think this is the lens to see in the coming days, madam.
And its extra benefit is that for hyperopia, it has the aquapore, so you do not need to do a PI even for hyperopic lenses.
And you can get the customization also.
Yeah.
If you have a very high cylinder, even more than 5 diopters, 7 or 8 diopters, you can get it customized. And they supply you within 2 weeks the customized lenses also.
I think the ease
so that
of
is also
availability,
one of the
yes.
benefits.
Yes, 2.2, because they have a new inserter which goes through 2.2. So even the higher power lenses, yes, 2.2, yes.
The ease of loading and ease of injection with this lens, if you compare with the Vision ICL, there are 100% difference because it's so easy to load and so easy to inject. It can go through 2.2. For that lens, you need almost 3.5 to 3.6 millimeter.
Not a single lens has been flipped inside. You can see that easy is this. No, when you are putting toric lenses, inject 180 degree, only you have to rotate 5 to 10 degree axis
minimal.
only.
It's minimal.
Depending upon that marking, you have to rotate, not whole lens to be rotated. Only 5 to 10
It's a smart toric, no, basically, because you have to position it at 180 degree and rotation is done automatically. Yeah.
Okay, with that, I'd like to thank all the speakers and the panelists for their valuable contributions. Thank you, everyone, and the audience. Yes, and we do have a small token of appreciation for the presenters. So Dr. Rajesh and Dr. Vanati, please come. And Dr. Rajendra Prasad, President of DOS, may please give it. And Treasurer AIOS may please, not Treasurer, he's the editor proceedings, Dr. Kudlu may please give to Dr. Vanati.